A very good morning to one and all present here for this webinar on by Dr. Kamal Janakiraman on the topic Basics of Diagnostic Imaging in Physical Therapy Practice. So before going to the topic, I'd like to introduce today's speaker, Dr. Kamal Janakiraman, who did his bachelor's and master's from India and did his PhD in sports in Guru Nanak Dev University, Amritsar. Along with that, he is now a registered physiotherapist in Alberta, Canada, and also a certified physiotherapist in vestibular rehabilitation, concussion rehabilitation, acupuncture, dry needling, champions performance specialist, and also specialist in diagnostic imaging in physical therapy practice. Sir, we are privileged and honored to have you in our university as a resource person and to enlighten the students of physiotherapy profession across the Gujarat and India and world with your speech. And also the topic which is quite interesting, that every physiotherapist can understand something about the diagnostic imaging resources from your side. And we welcome you, sir, for this session. Over to you, sir.
Okay. Thank you, Mr. Bala. And good morning, everyone. Are you able to hear me?
Yes, sir.
Okay, good. Okay. It's nice to connect with you all on this webinar. It's a nice new experience for everyone, and it's going to be a good informative session for you all. So we are going to the topic now. I'm going to share the screen. Okay. Just a sec. Okay. Okay. So this is our topic today, basics of diagnostic imaging in physical therapy practice. First of all, I thank Mr. Bala and Charasat University for giving me an opportunity to take this webinar. And I'm really happy that I'm able to share some of my knowledge with you all students and others. So coming to the point, why do you want to study imaging? I can hear someone that your principal wants you to do so. This is the one drawback, right? I can't get the feedback from your students. You should like to talk with the students and get the feedback and everything. See, anyway, at least you're able to share the knowledge. Okay, so why do you want to study imaging? The success of rehabilitation depends on the effectiveness of our evaluation. So the more the thorough evaluation we do, the more we can do on our rehabilitation program. So the imaging can provide an objective visual aspect of the evaluation that makes the expertise of the clinician more comprehensive. So that is the reason we do the imaging. So imaging was not done by not evaluated by the physiotherapist before, but as we are progressing now, more and more physiotherapists starting to read the images and starting to develop the rehabilitation protocol with that. Traditionally, the field of imaging has been the domain of physician. Only the doctors order the imaging. So rehabilitation clinicians, from this point, if I say clinician, it is going, I'm mentioning the physiotherapist, okay? The clinicians have generally excluded themselves from interaction with the imaging. Studying the patient's diagnostic images was rarely considered, and simply reading to the radiologist X-ray report was accepted as sufficient. Traditions changed. Rehabilitation clinicians have discovered that the knowledge of functional anatomy is an excellent foundation for visually comprehending diagnostic images as well as correlating clinical findings with imaging findings. The inclusion of diagnostic imaging courses in educational professional settings. For example, a lot of USC Canadian courses have this diagnostic imaging course along with their professional course, which is giving the clinicians the confidence to dialogue with the radiologist and gain relevant information from the radiology report. And most significantly, you can view the diagnostic images with your own eyes. So, why do clinicians need to view diagnostic images? Okay. First, a more comprehensive evaluation is obtained. What do you mean by that? So, okay. Second is the information the clinician seeks is often of a different nature than the information of the physician seeks and of a different nature than may be described in the radiologist report. For example, the physician maybe need to know whether the fracture has healed so that he can remove the cast and can send to the rehabilitation. That is the need for the doctor to view the diagnostic image. Whereas the physiotherapist, why he needs to view the diagnostic images, he needs to know whether the union is perfect or whether there is a malunion. If there is a malunion, whether it's going to cause any deformity. If there is a deformity, whether it is going to cause any restrictions or limitation in the adjacent joints. Accordingly, a physiotherapist can formulate a goals of treatment. That is the need why we need to view the diagnostic images. Having the physiotherapist serve in a physician extended roles has been shown to be an effective method in reducing the number of extraneous images ordered while maintaining high levels of diagnostic accuracy. Physiotherapists or physical therapists have been shown to have similar diagnostic accuracy as orthopedic surgeons and be more accurate than non-orthopedic providers. This is according to the research. Additionally, physiotherapists in this physician extended role have demonstrated no difference in patient outcomes. A greater than 50% reduction in radiography examination, a higher level of patient satisfaction, as well as increase in access to orthopedic surgeons and physiotherapy job satisfaction. Remember one thing, today's lecture is not about reading images, and because the radiology is a big field. The radiology usually they do their course for 4 to 5 years to do the reading of images. Just a 40 minutes class or 1 hour class, you're not going to be an expert in reading the images. Okay, so keep in mind this lecture is not about reading the images. Now, what is radiology? Radiology is the branch of medicine concerned with radiant energy and radioactive substances, including X-rays, radioactive isotopes, ionizing radiation, and the application of this information to prevention, diagnosis, and treatment of the disease. Physicians specializing in the radiology are called radiologists, and the professional technicians that produce the images are radiographers. Some brief history about the imaging and physical therapy practice. As physical therapist practice evolves, including patient direct access, the ability to refer patients directly for diagnostic imaging could enhance efficiency and the effectiveness of care delivery. The ability of physical therapists to refer for diagnostic imaging is a concept that has been in existence for decades. For an obvious example is the US military, where since 1972, physiotherapists practice as a direct access providers with imaging privileges. So it's been that long since the PTS started providing imaging reference. So what is the purpose of this lecture? What are you going to study in today's 42-hour class? Understand the use of diagnostic imaging within the scope of your physical therapy practice. Second, understand the physics, principles, risk, and benefits of diagnostic imaging. Third, learning about radiographs, various densities, and viewing radiographs. Next, make judicious and evidence-informed decisions on when to use imaging. And finally, communicating effectively with radiologists when making a referral. So these are the topics we're going to learn today. And the imaging, it's a broad area. It includes the radiographs, and it ultrasound, CT scan, MRI, a lot of things. But since this is a basic course, a basic lecture, we are going to focus mainly on the radiographs, which are nothing but the X-rays. Okay? So, what are the key takeaway points from the introduction? The knowledge about radiology helps clinicians to view diagnostic images with their own eyes. It helps clinicians to obtain more comprehensive evaluation. The purpose of this lecture is to learn basics of radiation, production of X-rays, understanding about radiographic images, effective communication with radiologists, and making judicious and evidence-informed decisions on use of imaging. Again, this lecture is not about reading images. The next chapter, basic physics and safety of radiations. So, what is radiation? Radiation is energy that is transmitted through space or matter. The different forms of energy used in medicine include mechanical, thermal, nuclear, and electromagnetic energy. Some of the examples for mechanical energy are ultrasonic waves and electrical. Thermal, the example is the infrared lamp. Nuclear, example is gamma rays or alpha particles. Electromagnetic energy, examples are visible lights or X-rays. So, the types of radiation and their penetration. Here the picture shows how far each radiation can penetrate. For example, the alpha rays can pass only up to the paper, where the beta rays can pass through the paper up to the wood. The X-ray can pass paper, wood, aluminium, goes up to the lead iron. The gamma rays goes to the same level of penetration, whereas the neutron can pass up to water or concrete. So these are the various types of radiation and their penetration level. Now, next important concept in radiation is ionizing or non-ionizing radiation. So what are those? Ionization is the process by which a neutral atom gains or loses an electron, thus acquiring a net charge. Ionization has the ability to disrupt the composition of the matter and as a result disrupt the life process. Hence, this is the reason protection against excessive exposure to ionizing radiation is significant importance in radiology. So this way you always say that unnecessary tests should be avoided, because every time you get exposed to an X-ray, you get exposed to an ionizing radiation. That is not good for you. There are two types of ionizing radiation present. One is the natural and the other is the artificial. Some of the artificial ionizing radiation in artificial ionizing radiation are medical and dental X-ray exposures, which constitute a significant greatest source of radiation exposure. Now, there is a classification of the non-ionization and ionizing radiation. So if you see the non-ionizing radiation, we have the power lines, which you see everywhere, the radio and cell phones we use, the microwaves we use in the kitchen, the infrared lamps, the normal bulbs. These are the non-ionizing radiation, which uses very less energy and which are not harmful. Whereas the ionizing thing are the ultraviolet rays, X-rays, and gamma rays. These uses more energy and this can cause some damage to the tissues. So these are some of the radiation dose examples. So usually the radiation doses are, the unit is millisievert, MSV. They usually say it MSV. Okay. So if we have 1000 MSV, that may cause you a radiation sickness. If you're exposed to 1000 MSV of radiation, that may cause the radiation sickness. For example, yes, typical cross Canada fat, because it's Canada, is 0.02 MSV. And typical chest CT scan will involve some in MSV. So there is a limit for each and everything we use. Again, this will give a clear picture. Radiation in daily life. So the normal annual dose limit for radiation worker, the people who work in the labs, in the X-ray department or CT scan, so their annual dose limit is 20 MSV. If they go beyond that, that's not good for them. 6.6 MSV is the average effective dose from a CT scan. And you can see 0.05 MSV is the average effective dose in a single chest X-rays. So these are the normal radiation we encounter in daily life. Even the normal food, drinks, buildings, soils can generate some amount of radiations. Again, the same thing. If 10,000 MSV of radiation is somebody exposed, a single dose can result in death within weeks. Whereas the 5,000 single dose, it will kill half of those exposed within a month. Again, if your 1000 MSV is exposed, then single dose can cause radiation sickness, nausea, but not death. And less than that, it can cause a lot of damage like DNA damage, egg and sperm cell damage, body cells damage, tumors or abnormal growth. So generally, the radiations are not good for our body. So that's the reason, again, I'm insisting, we have to reduce the number of images as much as possible. Try to get your evaluation as much, clinical evaluation as much as possible, and only in case if it is needed, you can go for the diagnostic imaging. So what is the acceptable radiation doses? In diagnostic imaging, no radiation dosage that is considered safe. Remember the principle always, as low as reasonably allowable. So as much as low is good. There is no fixed point for the radiation doses. So when you're sending someone for the imaging, these two questions should always come in your mind. Do the benefits outweigh the risk? Will the imaging alter the physiotherapy management? These two things is always should be in your mind when you're going to prescribe an imaging for a patient. If your answer is no for both, then you don't have to refer to your imaging. For example, mild OA hip. In case of mild OA hip, the imaging provides little additional diagnostic value beyond the clinical exam. Most probably, it will not alter the physiotherapy management. Here, the benefit do not outweigh the risk because the risks are more than the benefits. So in this case, you don't need an imaging. Whereas in other conditions like head injury or cervical spine fracture, the imaging is critical and potentially life-saving. The imaging will direct the management. Here, the benefits outweigh the risk. Here, you need an imaging to save an individual. So it is acceptable. So what are the takeaway points from this session? There is always some risk associated with the exposure of patients to ionizing radiation. Ionizing radiations can cause cellular damage and some body tissues. This is why that there is no safe dosage in the medical imaging, and the clinicians should always work on the premise as low as reasonably allowable. our next chapter is generation of radiographs. Again, here I have to say something. It is normal for any lay person to call it as an X-ray, but as a healthcare provider, as a physiotherapist, it's always better to mention as a radiograph, because the term X-ray is always a misleading one. So it's better to always call it as a radiograph because you're in healthcare profession. Same. Whether to call it as a radiography or X-rays. It is acceptable for a layperson to refer to a radiograph and X-ray, but a knowledgeable clinician and health workers should avoid the term X-rays and always mention radiograph. Okay? What is a radiograph image? A radiograph is an aerial image of an anatomical body part on a film or image receptor produced by X-rays passing through the tissues. Okay? You can see the pictures clearly. It passes through the beam, it passes through the body tissue, and down it recorded as this like this. So this is a small flowchart to explain how to generate the radiograph. First, what you need is a means to generate the X-rays. That's called the X-ray tube. A means to beam the X-rays, the X-ray machine and a collimator. A means to capture energy, the image receptor and cassette. Don't worry about this, I'm going to explain detailedly later on. A means to store remnant X-ray as a latent image or the digital receptor. And finally, a means to convert the latent energy to an radiographic image that is usually done as an image processor or computer. So generally, this you can say, this is an image generator where from the X-rays pass onto the human body and down the X-ray detector where it receives the images, latent images. From this, it is connected to a computer where it is converted into a digital image. This is a general setup of an X-ray production. Okay, so the filament electron cloud, from here the electrons are passed into the tungsten target from which the X-rays are produced. I'm going to show a small video which explains neatly how the X-rays are produced. Okay, just a sec.
Production of X-rays. The lab setup shown here was designed by Coolidge, and hence it is called Coolidge tube. It contains a highly evacuated glass bulb containing a cathode, which is a tungsten filament, and anode, which is a target made up of metal of high atomic weight. The pressure inside the bulb is maintained at 10 to the power of -6 millimeters mercury. When the cathode is heated by passing a current through it from a low-tension battery, it emits cathode rays. These rays are nothing but electrons. The filament is surrounded by a molybdenum cylinder, which is kept at a negative potential to the filament. This repels the electrons further, and hence the electrons form a fine pencil beam at the center of the cylinder. This pencil beam is also accelerated by the cylinder towards the target. The target is made up of a copper block in which a piece of tungsten or molybdenum is fixed. High thermal conductivity is used to carry away the heat generated to the cooling setup. Here we use copper, which is a good conductor of heat and can take the heat away from the molybdenum metal towards the water cooling system. The target is also tilted at an angle of 45 degrees, causing the electrons to hit at an angle. This will produce the X-rays almost perpendicular to the electron beam. A very high potential of 20 kV is applied between the source and the target. Due to the high potential difference, the electrons are accelerated towards the anode and it hits the metal. When it hits, the kinetic energy is transferred to produce X-rays. The intensity of the X-rays depends on the number of electrons striking the metal target. So, if we can increase the rate of electrons emitted by the filament by increasing the current flowing through the filament, then we can increase the intensity of the X-rays.
Okay, I think you got an idea with this video how the X-rays are produced. That's a basic lab setup to see how the X-rays are produced. But the recent equipments are well advanced. Okay, so this is what you say as a Coolidge tube there. One thing it doesn't have is the window here. The window allows only selected amount of X-ray to pass through it. Okay, once the X-ray pass through that, then it goes to the second set of lower shutters. Again, it filters up more amount of X-ray and only it passes down. Now, the next thing you need to know about is the attenuation of X-ray beams. So what that means? Attenuation is a reduction in the X-ray photons as it passes through the body part. Attenuation results from absorption and scattering of the X-ray beam. In this picture, you can see a lot of X-ray photons is passing through the body tissue. Some are absorbed by the tissues in the body. Some of the photons are scattered and moves out. Only few X-ray photons are passed through the body and goes to the captured by the image receptor. So again, the same picture from the X-ray tube. The X-rays are passed and only few photons reaches the image receptor. The latent image is the variation in the remnant radiation that hits the image receptor or passing through the body part. These are the old one, the plain film radiography, which I used before, which used like a cassette. Now the modern radiography uses the digital radiography. The advantages are that digital images can be manipulated electronically to improve contrast, magnification, and overall readability. Also, the images can be easily stored or shared. And this you can see the difference between a plain radiography and a digital radiography. This is the difference how it varies between both. So some of the key takeaway points from this are: a radiograph is an image of an anatomical body part on a film or image receptor produced by X-rays passing through the tissues. The image is generated from the remnant X-ray radiation that passes through the body and hits the image receptor. Radiographic images can be a plain film or a computer generated. Now, so we saw about the radiations, then we saw how the X-rays are produced. Now, we're going to see the radio densities and shades of gray of the X-ray beam. Now, first, coming to the radio density. Okay. So each substances has their own density. And when you see the X-ray, there you see different colors, right? Black, gray, white. It all depends upon the density of these substances. Okay. For example, the air has the least density, then the fat, water, muscle, bone, barium, lead. The lead has the highest density. When I come to the mostly with the X-ray in human body, mostly you'll encounter the first five: air, fat, water, muscle, bone. These are the 5 things you normally see in an X-ray. Okay, this gives a clear picture. So, increasing radio density, because air is the lightest with radio density and metal is the highest radio density. Okay. When it is decreased radio density, the image is called radiolucent. When you have a high density, it is called as a radio opaque. Okay. So when you see on an X-ray, if you see a dark black area, that means that is an air. If you see a gray area, that is a fat. Light gray area, it is a water. And bone, it's a white, and metal, it's a bright white. So this is how you can identify the structures on an X-ray. I'll show you a picture now. Now, this gives a picture here. For example, the air has black pockets there, which is an air, and light gray, which is an fat there. Gray is the fat there, and bone, which is white, and water is a little bit gray, like it's told here. Okay. So it is the variations in the radio density between the tissues that allows different anatomical tissues to be identified on the radiographic image. For example, air is seen here in the disc around the edges of the radiograph. Water, muscle and soft tissue have the same density as water. Fat is seen as a dark streak, and bone you can see as the white. Now, sometimes the X-rays are done along with the contrast media. So why they do that? The contrast media can help to visualize soft tissue, which are not normally seen. For example, bearing coats the lining of the gastrointestinal system, so it is used to visualize the GI tract. Because GI tract is normally not much visible with the normal regular X-ray, so they ask the patients to drink some contrast media, so that after that they take an X-ray so they can visualize the GI tract. Now, so commonly the physiotherapist sees two kinds of radiography. One is the chest, another is the orthopedic. These are two common things. So what does the chest radiography can identify? Normally, example, it can identify out size, lung areas not filled with water, with air, solid tumor, collapsed lung, fluids or infections in the lung piece. Some of the examples, you can see more. Same way, the orthopedic radiography can identify fractures, dislocations, degenerative joint conditions, bone tumors, fracture healing, and check hardware. For example, you can see here the total hip replacement here of the hip. You can see the check the hardware positioning properly there. Similarly, you can see some of the pleural effusion there. So the conventional radiography provides little differentiation between various soft tissues and is not useful for identification of soft tissue disorders. Conventional radiology is also less sensitive. When I say conventional radiography, it means the X-rays. It is also less sensitive than MRI and CT scan to early changes associated with stress fracture, bone infection, and tumors. Key takeaway points from this chapter. First, the different tissues are recognized as one of four varying shades of gray on the image. Bone appears white, fat and water appear shades of gray, where air appears black or dark. Conventional radiology or radiography is useful to identify fractures, dislocation, bone tumors, and degenerative joint conditions. Conventional radiography is not useful in identifying soft tissue conditions. Now, next topic we're going to say is the radiographic views, projections, and positions. Remember always, when ordering image, more than one view is always required. Clinician must always remember this when ordering conventional radiographs. You can see here, 2 cups of milk when seen from the top, they look same. But when you look from the side, you can see the difference. Same thing. There's an example here. This is an AP view of skull. You can see a knife impaling to skull on the right side. But it's very difficult to say it is in the back of the skull or the front of the skull, just with one image. Now, when you take the lateral view of the skull, now we can clearly see that the knife is impaled through the frontal bone and the blade and extends down to the temporal region. So this is the reason we always say two views are needed. Remember, whenever you're going to ask for imaging, 2 views are needed. One view doesn't provide any information. So what are the common projections of radiograph? common projections are anteroposterior, posterior, lateral, AP or PA oblique views. There are lots and lots of views are present, but these are the common projections normally ordered. Now, this is the anteroposterior projection. Okay. During AP projection, the X-ray beams pass from anterior towards posterior. In the posterior anterior, the X-ray beams are passed from posterior to the anterior. Lateral projections, when you're viewing the lateral images, you are viewing from the perspective of the X-ray collimator. Again, when you say right lateral projection, your right side is close to the image receptor. When you're seeing the left lateral projection, your left side is close to the image receptor. The same thing I said you. The left side of the chest is close to the image receptor in a left lateral position. Oblique position. In oblique position, in the right posterior oblique position, the patient lies on the right side, slightly obliquely, and the image passes from anterior to posterior. In the left anterior oblique position, patients lie on the left side, in the oblique slightly tilted. Again, the rays pass from the posterior towards anterior. The same thing. So these are the various kinds of projections are present. Okay. Now I'm going to show you some of the projections. This website will give you the radiography for a lot of all the body side. For example, let us take, where do we take? Let us take, where is a good thing to see all this. Okay, knee. Let's take the knee. So this is the AP view of the knee, and you can see the clearly what are the structures in the AP view, adult knee AP view, and this is the lateral view of the knee. Again, you see the structures, what are structures are present. This is all the right knee, and this is called as a skyline view of the knee, which is made to visualize.
Kamal sir.
Yes.
You have to share the screen with radiograph in it.
It's not sharing.
Yeah. You have to minimize this PPT and then you have to share that screen.
You're not able to see the screen.
No, I'm able to see the screen of this projection positions, but Wiki Radiography Net you have shown, no, so that is not getting seen. You have to share that screen. WikiRadiography.net.
Oh, just a second. You're able to see now anything?
You click that WikiRadiograph.net and you share that screen. You have to minimize this PPT. Only one screen can be seen at the time. Yes. You minimize that one and show.
Okay.
Yes, you minimize your screen.
Just a second. I'll copy that.
The WikiRadiography, you can just click a link and then you can share that link.
Still you're not able to see?
No, sir, you have to share that screen. It is not getting shown.
Okay.
1 second, I'll just try to share. You minimize this. You minimize the screen.
Yeah. I got it. Just a second.
Yeah.
Just a second. I'll do that.
Minimize it,
Yes.
and then you can show that.
Yes. I'll open this one. Okay.
Yes.
You seeing now?
No, you minimize this one. Minimize.
Still no?
No, you minimize this one, and you can show it in another browser. Wiki Radiography. You want? Shall I open it?
Yeah, I can open it. You can share. Share your account.
You can open in the new browser.
Yeah, I'm just checking.
And then you share that screen through this thing. Yeah, now it is coming. Yes, yes.
It's coming?
Yes, sir.
Okay.
Thank you.
Okay,
Yeah.
Okay, fine. I'll go through again.
Yes.
We are seeing the shoulder. Showing the lower extremity knee. Okay. Yeah. It's the knee. Sorry for the delay. The knee AP view. This is the AP view of the right knee. You can see the structural marking. What are all the landmark marking over there? And this is the lateral view of the knee. You can see. And this is called the skyline view. This is especially to see the patella, articular surface. And this is the intercondylar view to see the articular surface of the knee. Okay, this is one. And you can also go and see the other. If you want to see one more joint, I can show you just one example. I can show one more joint. I'm looking for the shoulder. Yeah. And again, this is shoulder, AP view of the shoulder. You can see the humerus, clavicle, and the scapula. You can see the acromioclavicular joint, greater tubercle, lesser tubercle, all the parts. And this is glenohumeral view. And this is the lateral view of the shoulder. And this is called the Mears view. This is mainly to see the coracoacromial arch, coracoid process, and the acromion. And this is an superior inferior view, which is these are some of the rare views they take. The common ones are normally the AP view and the lateral view. These are the common things. Okay. So let us go to our presentation now. I'll go to presentation now. Okay. Are you able to see the presentation now? Good. Okay.
Yes, sir.
Okay, good.
Fine.
Okay. So the key takeaway points from this chapter is main thing, one view is no view. The common projections include AP, PA, lateral, and oblique views. The position refers to the physical position of the patient and to the side closest to the image receptor. The physiotherapist ordering images should have the knowledge of the required projection. Only if you know the projections, what you can see in those projections, then you can order the projections. If you don't know how the AP projection is going to come, how the lateral is going to come, then you cannot order any image. Next is viewing the radiographic images. Viewing radiographic images is helpful to understand how to view an image and be able to systematically extract information. This helps with understanding the imaging report and allows the physiotherapists to speak the language of radiology so they can communicate effectively with patients, radiologists, and radiographers. So, some of the things you should know when viewing the images. First thing is the side marker. What is the side marker? First, you should know whether the image is an EP view, PA view, oblique view, or lateral view. First thing. Second thing, marker is whether it is the right side or the left side. And third thing, what structures are involved. Knee joint, here it is knee joint, which joint is involved. These are called as the side markers. Next, you should look for the personal identification markers. What are those? The name, there always the name will be there. Then gender, you can see, male, date of birth, this is the date of birth, 1951, Jan 19, institution ID, this is the institution ID, and date image was taken, 2009, November 2009. So these are called as the personal identification markers we should look for. Then, image quality factors. What are the factors just going to affect the image? There are 4 factors: image density, image contrast, radiographic details, and radiographic distortion. The image density and the image contrast going to affect the visibility of the image. The radiographic details and the radiographic distortion going to affect the focus of the image. I'll explain you. For example, the first thing, the image density, I say image density. So this is an X-ray which is underexposed. That means less amount of X-ray passing through that causes this kind of image. This is the correctly exposed picture where you can clearly see the joints properly. And this is the overexposed image where more amount of X-rays are passed through the body tissue, then you don't see anything. Okay. The next thing is the image contrast. This is high contrast image, this is the low contrast image. So these 2 things affects the visibility of the image. Next we'll go for the radiographic details and the radiographic distortion. Radiographic details, recorded detail. Here you can see when the X-ray was taken, somebody voluntarily moving or moved, that results in the distorted image. The image is not clear. And in this involuntary motion, like movement of the heart or something, can cause a little bit distortion too. So this is called the radiographic recorded detail, which can affect the focus of the image. And radiographic distortion. So what is radiographic distortion? I think this is a normal X-ray image. The X-ray beams are passed, the bone is aligned properly, the bottom image receptors are aligned properly, so you get a good image on the X-ray. In case when the X-rays are taken, your body part is a little bit tilted to one side or other side, then the image you get in the receptor is not normal. Is either bigger to one side or smaller to one side. Similarly, these changes could also occur. Here, the body part is aligned properly, but the image receptor sides, they are tilted, they are not proper. In that case, again, the image you're getting is not perfect. It is not good. Okay? So when you need to get a good image, your body part and the image receptor has to be perfectly parallel to each other. Now, when I get an radiograph, how are you going to view it? There is an ABC search pattern of viewing radiographic images. So I'm not going to explain detailedly about this because it's a very, very big topic. So I'm just going to go through just this flow chart. So what are the ABC stand for? A for alignment, B for bone density, C for cartilage spaces, and S for soft tissues. So when you get a radiograph in your hand, first look for the alignment. Look for the general skeletal architecture, general bone contour, and the alignment of bones to adjacent bones. For this, you should know the anatomy properly. If you don't know the anatomy properly, then you can't do anything with these ABCs. Okay? To view the radiograph, we should be good at anatomy. Okay? So next, B is the bone density. General bone densities, textural abnormalities, and local bone densities. You have to see that. You have to scan one by one. First you scan the alignment part. Then you're looking for the cartilage spaces. You're looking for the joint specific. You're looking for the subchondral bones. You're looking for the epiphyseal plates. Okay? The last thing is the soft tissue. In soft tissue, you're looking for the muscles, fat pads and lines, joint capsule, periosteum, and other soft tissue findings. So you're finished scanning one by one, so you can find where the abnormality is present. Okay? This is how you're going to view the radiographic images. So what are the key takeaway points from this chapter? Orientate image correctly in the viewer. Check side up to body marker. That's important. Check person ID markers, name, age, sex, all those things. Check image quality, density, contrast, detail, and distortion. If something is not correct, then you have to send the patient to retake the X-ray. Search systematically using ABC method of search patterns. Next is a clinical decision-making framework for the appropriate selection of diagnostic imaging. So how are we going to decide whether this patient needs an imaging or not? That's called the clinical decision-making framework. Okay. So some of the important things required are the clinician knowledge, clinician experience, and patient clinical context. So first, all these things will influence in making the decision. The clinician knowledge is experience in evaluation and prescription, and what is the patient condition. All this is essential. So first thing is the physiotherapy diagnosis or hypothesis, what you make. Then you have to think what additional information is needed. Then will the imaging will get the information needed. What do clinical decision tools suggest? I'm going to explain about this, what this means, clinical decision tool. Will the imaging alter the management? Do the benefit outweigh the risk? These two things I told previously. Has the imaging already been done? Which imaging modality is best? So you should ask all these questions before you prescribe someone for an X-ray or ultrasound, whatever it is. Okay? First is the diagnosis. Then you have to think whether you need more information, or then you have to decide whether the radiograph is going to get the information. Then you have to think about whether it's going to change the management. Is there less risk or more risk? Then which is the best imaging modality? Okay. This is another flow chart. Okay. So physiotherapy assessment you do. First, whether the physiotherapy is indicated. If yes, you treat and monitor progress. In some case, you may need more clarification, then you can consider imaging. Sometimes physiotherapy indicated, you're not sure. You need some info. It could be imaging or lab test or something, then you may consider imaging. Sometimes the physiotherapy is not indicated and there are no red flags. Then you can refer back to the physician. If the condition is not within the scope of physiotherapy practice, then you should leave the management decision to physician. Physiotherapy is not indicated, but there are red flags. Red flags are some of the serious things you need to pay attention immediately. Okay? You have to decide whether the urgent or semi-urgent. Accordingly, you have to send them to emergency department or send them to the doctor immediately and leave the decision to the physicians. Okay, this is the flow chart for your decision making. The last chapter we're going to discuss is the communication with the radiologist. How you are going to communicate with the radiologist. We talked about everything. The last step, an important step is You're going to refer someone to the radiologist. How are you going to do that? When you're ordering image, you should know which test you're going to take, when you're going to take, where you're going to take, how you're going to get the results, and what you're going to do after getting the results. First, deciding to image. Same thing. Are the results going to affect my management? Has imaging already been performed? Do they benefit outweigh the risk? These questions you have to always keep asking when you're going to refer for the imaging. Which imaging test are you going to do? In Canada, we follow a lot of criteria. We have the Canadian Association of Radiology guidelines. We have American Society of Radiologists appropriate criteria. And there are clinical decision rules we have, like Ottawa ankle and knee rules, Canadian C-SPAN rule. So we'll go through all these things to select an appropriate imaging test. Things you need to know before ordering imaging. First thing, know your local radiologist. Know how to require an imaging test. You should know how you are going to view the images. You should know how you're going to receive the reports. These are things you should know before ordering the images. Before that, who is a radiologist? A physician who has undergone residency training, usually 5 years in diagnostic imaging. The subspecialist radiologists undergo 1-2 years further training. So the subspecialist may be system specific or technique specific. Remember, when you request an imaging study, you are communicating with the reporting radiologist. When you're communicating with the radiologist, requisition must be sent for each exam. And if you have any question, you can phone them. And the radiology requisitions should have patient demographics, clinical information, and the contact information. I'm going to show you some charts. So this is the normal X-ray requisition form, which has the name, address, everything, what kind of you're going to do, X-ray, ultrasound, nuclear medicine, mammography, or MRI, CT, everything, and you're referring physician information, everything. Okay, and this is one sample requisition, which I will say is an inadequate clinical information. Everything is there, basic information, the X-ray requested, right knee, weight bearing views, and relevant history. We say there's a knee pain. I say this is the inadequate information. Why? Because the next thing, you can provide a better information, like instead of providing just the knee pain, you can provide it's a medial knee pain with history of osteoarthritis, so that a radiologist knows something why you are sending down. And more than this, I'll say this one has the better information, like chronic medial knee pain, history of osteoarthritis, recent locking, whether there is any loose body. This is the reason you are sending the patient to the radiologist. You see the difference between the first one, just the knee pain, and the last one. So this will give the radiologist a better idea why a physiotherapist is asking for the X-ray, so that he can provide a better report. The radiology report should have all those things: patient demographic history, positive, negative technique findings, observations, conclusions, and recommendations. This is a sample radiology report. You can see the demographics here, history, chronic medial knee pain, history of OE, locking, loose bodies, finding. This is what we provided, right? This is what we provided in the sheet, requisition sheet. Findings, what the radiologist found: narrowing of the compartment, lateral joint space normal, bony element maintained, no loose bodies present. However, there is a strong clinical suspicion tunnel disc could be performed. Impression, mild OE, moderate OE, and recommendation, tunnel views. So this is how a sample radiology report looks. Acting on unexpected or abnormal results. You should have a plan when you get an abnormal results. You should inform the family doctor by phone or fax. Sometimes you have to refer to a specialist, and further imaging can be suggested by the radiologist. And the key takeaway points from this lecture are: making informed decision about imaging your patients. You can't just send all the patients for imaging. You should have making informed ethical decisions. Communicate effectively with your local radiology practice and request imaging in a way that will provide you the best possible reporting. Respond to abnormal results appropriately. Okay. So that's the end of all the chapters. Let's go to the summary. So what we learned today is the basics of imaging, basics of physics behind radiations and radiography, that is production of X-rays, and how the radio densities and different shades of gray are present helps to differentiate various structures in the body. What are the various radiographic views, projection, and positions, like AP, lateral, oblique views we have, and viewing radiograph, how are you going to view the radiograph, and the clinical decision framework of physiotherapist, how are you going to decide whether the patient needs imaging or not. That's called the clinical decision framework. And finally, communication with radiologists and reading reports. That's again an important thing, because the better your occasion, better report you get. Okay? And I need to acknowledge this thing. Most of my current lecture is from the Fundamentals of Musculoskeletal Imaging book by Mechanis, and some of the lecture notes from the course I did from the University of Alberta, Edmonton, Canada, and some of the images, videos from Google search. Thank you everyone for listening patiently for this 1 hour. If you have any doubts or anything, you can ask me now. Thank you.
Thank you, sir, for your wonderful presentation. I think you can close down the screen, sharing screen.
Pardon?
You can close down the screen, sharing screen.
Okay, yeah.
And we have gone through the Facebook Live and then YouTube Live also. There is one question which has come from YouTube. I have just shared with you the thing.
It's in chat.
What is the the question is from Ms. Pooja Krishnan. What is the meaning for the phrase change the management, which was given under the topic? The questions which should be asked to ourselves often. This is the question which is asked.
Changing the management, it's our goals. How we are going to change your goals, which is the priority for us, whether range of motion is the priority, muscle strength is the priority, or functional goal is the priority. That's what is the management goals, not with any modalities. How we are going to progress? We're going to progress with the partial weight bearing to full weight bearing, or going to start with the open kinematic chain to closed kinematic chain exercise. How we're going to progress the management. That's what it means. The radiology give an idea about that. Instead of just focusing on the structure which is involved, you're going to also look for the other structures which are going to be affected by the other side. So we're going to concentrate on the other side too, not just focusing on the, for example, if you have some problem with the elbow, it's going to affect your shoulder also. Okay? If the elbow is not healed, it's going to cause stiffness in the shoulder, then you're going to work on the shoulder too. That's why it's going to change the management. Sometimes the radiology could change your treatment. We're not able to visualize for the lumbar, for example, that's low back pain. Sometimes the X-rays or the MRI CT scan can provide you some details like listhesis. Then your management could be changed, some flexion exercise to extension exercise, something like that. That's what it change management. The imaging can change your management, how will go.
Thank you, sir.
That explains. Yeah.
I just got one question. How often the patients are referred for X-rays there in Canada?
There is a lot of article on that. I can show you. The reference is a lot. People are referring a lot actually. The government is trying to bring that level down, but there are a lot of referrals in X-rays. Even the physiotherapists can refer, but usually the physiotherapy referral are comparatively reasonable when compared to the physician referral. Because as a physiotherapist, we know what's happening inside. We don't usually refer for all the knee pain to the X-ray, whereas the physicians, they just refer most of the clients here for the X-rays.
So how frequently a patient is exposed to X-rays? Suppose he goes to physician and he comes to therapist. So whether the repetition of X-rays is happening it or it is
No,
any
no,
time
no,
duration is there.
repetition does, no, there is no repetition happening. If we know the physician already is given for the X-ray, then the therapist will not order for an X-ray. There is no repetition occurs. Only if the physician doesn't order and the therapist thinks that it is required, then therapist order. There is no order, there is no, both of them doesn't order together.
Thank you, sir. Any questions from the audience? Any questions from the audience? Fine, sir. So it was wonderful to listen to the lecture and quite interesting to know about the basics about how a physiotherapist should know it. Because we learn about physics, we learn about the how to read the X-rays, but rarely to get flow of process. I think today we are able to get to know from your lectures, and probably this should be
Actually,
one of
this
the.
is very, yeah, actually this is a very extensive thing. To concise to a 40 minutes 1 hour class is very difficult. It's a very, because this I studied for nearly, it's a 3.5 4 months course. I think. Okay, so it's very difficult, concise.
Okay, so it was wonderful to listen to you, and then hope our audience would have got benefited, also the students. So at least this will be a feather for them to know more interesting things in the radiology. So one new thing which I have come to know about the wikiradiography.net, which I've gone through the website also. It is quite interesting to know about the clear radiographs, and then we can learn something from that also. And I just want to add upon Kamal sir that we have got an elective course in masters, imaging in physiotherapy.
Oh, that's good.
So the students choose in the first year of MPT, they have got this option. They can choose either physiotherapy education or physiotherapy imaging in physiotherapy as a course, elective course.
Oh,
So under that
that's
course,
good.
like we have been teaching imaging in last 3 years for our students, where they are taught about the basics of imaging, and then they thought about the exposure to the other CT scan center, other places and all. But I think this video also like we'll be sharing with the first year students. So if required, then we might utilize your further resources. Thank you, sir.
Yeah, because I didn't talk about anything about CT scan, MRI, ultrasound, because there's no way I can do that here. That's why I just restricted to only the radiograph. We can go beyond that.
So thank you once again from on behalf of our university, Charokter University of Science and Technology, and Ashok and Ritapet Institute of Physiotherapy, giving your valuable time. Thank you, sir.
Thank
you very much.
Thank you so much. Thank you everyone for listening.